Hi, everyone. Hey, here we are in this beautiful weather, right? We got lucky with the weather, but I want to just say a little bit about the weather. First of all, I'm Shirley Kessel. I'm the executive director of Miles for Migraine, and really happy that so many of you have shown up today. I think you're really going to enjoy our program. It's also being aired virtually on Zoom right now. So hello to all of our Zoom watchers out there. I want to first start by saying that I know we're in the sun, and this is a trigger for many of us, including myself. So, if you feel that you need to move any place you want to move, there are places to sit in the shade. Around here, some folks sitting up on the hill. You can turn your chair to face the back of the speakers. They will not be offended because they're both amazing headache specialists and will understand that. And I also just want to say that uh, I'm really grateful that the sponsors who have decided to work with us today are here so they can really be a part of this community because a lot of times patients with migraine and other headache disorders, we're kind of left to fend for ourselves, right? We spend a lot of time in isolation. We spend time in a dark room. We have friends, families, coworkers, employers who don't understand us. And so it's really important for you to be part of this community and to come out and learn everything you can about your disease, whether it's migraine or another headache disorder. It's good because we need to keep talking. We need to open up. We need to share what our experience is like, not just with your fellow or sister, friend, or foe, or whoever is someone that lives with migraine or another headache disorder, but also strangers. We need to start really speaking up about this disease. And so today you're going to hear about some of the disparities that we face in our community because it's happening all around the country that we know many people of color are not getting diagnosed and are really walking around just, suffering and not ready or willing or trusting enough to see a healthcare professional. And we get that. But that's why we put this program on today, because we want to make you feel welcome into our community. We want you to understand as much as you can, as much as you want to know. And we have events that go on throughout the year, not just this one, not just a race. We have a support group, we have other social programs, and we want you to be part of our community. So, with that, I am going to bring up to the podium right now Christine Pasusne from Amgen, which is one of our sponsors. And she is going to introduce to us our speakers. Christine.
Hi, everyone. So I have the pleasure of introducing to you our first speaker. Dr. Spears is the Regional Medical Director of Neurology and a headache specialist at the University of Pennsylvania. He is a fellow of the American Headache Society and the American Academy of Neurology. He received his Bachelor of Science degree from Michigan State University in East Lansing, Michigan, and his Doctor of Medicine from Wayne State University School of Medicine in Detroit, Michigan. He completed his internship in internal medicine at Akron General Medical Center and his residency in neurology at Albert Einstein Montefiore Medical Center in New York City, where he served as the chief resident in his final year. He completed a fellowship in headache and facial pain at the Headache Institute at the St. Luke's Roosevelt Hospital in New York City and has practiced headache medicine for the last 17 years. He is board certified in neurology and headache medicine and has contributed to the field through education and teaching of medical students, residents, and fellows, and is also published in peer-reviewed journals. So without further ado, please join me in giving a warm welcome to Dr. Roderick Spears.
Thank you for the warm welcome and good morning. Um, All right, so we're going to talk about migraine this morning, a subject all dear to our hearts, I think. Okay, so just an overview of what we're going to talk about this morning. What is migraine? We're actually going to talk about that. How is it diagnosed? How can you recognize it? We're also going to talk about the impact of migraine, some new treatment options for migraine, and then how do you seek help for migraine? Sorry about this design. Okay, so first of all, migraine is considered to be a primary headache disorder. So it does not have an underlying cause such as an infection or a tumor or anything like that. It would tend to be genetic or spontaneous in onset. Um, it is diagnosed based on specific criteria. Typically, migraine in the majority of patients is a headache only on one side of your head or unilateral. It can be bilateral in about 40% of cases. Most people will describe it as a throbbing or pulsating type of headache, but intense pressure or sometimes sharp and stabbing is okay. It typically is going to be rated a 6 or higher on a severity scale. Left to itself, it's going to last 4 hours to 3 days untreated. And it comes with associated features of becoming sensitive to the environment. Typically, you don't like light, you don't like noise. Sometimes you're sensitive to odors. For some people, there's nausea and or vomiting, and routine physical activity makes it a whole lot worse. So it's typically a disorder associated with disability. So when you have it, you don't want to move. You want to retreat to a dark, quiet place and either sit in a chair or lay down. So people end up either seeking help or suffering in silence with this disorder because you can't take care of your family, you can't go to work, you can't do the things that you want to do with your life. At the bottom of this slide, I wanted to mention the International Classification of Headache Disorders, which is kind of the Bible of headache medicine, from the perspective that it's specific criteria for headache disorders across the board. It was first done or initiated in 1988, and it's been updated 3 additional times or 2 additional times on top of the 1988 version. Initially, it was designed for research purposes. So going to the FDA, you need to have specific criteria for what you're looking at and when you design your clinical trials. But it's very useful in clinical practice, and that's where that diagnostic criteria for migraine comes from, the International Classification of Headache Disorders. So there is something official we can point to, because often people will say, hey, the MRI is normal, the neural exam is normal. How do you know this person has migraine? Well, we actually have criteria. I want to talk a little bit about migraine aura. And the first thing is that migraine aura is actually less common than migraine without aura. It only occurs in about 25 to 30% of people, but I've met many people over the years that will tell me they don't have migraine because they don't experience aura. And what that is that's in most cases a visual change that occurs prior to the onset of pain. It can last anywhere from 5 minutes to 60 minutes, and then it's followed by a severe headache. There are other types of aura that are more complex. Stroke-like symptoms, numbness, tingling, language disturbance, mental confusion, that let people know that a migraine is coming. So migraine, it has a significant impact on society. It affects about 40 million people in the United States. That's a pretty, that's about 12% of the population. It affects 18% of women, 6% of men, and about 10% of children have migraine. And so if you think about what I described previously, a disorder with severe head pain, sensitivity to light and sound, nausea and vomiting, lasting 4 hours to 3 days, affecting 40 million people in the United States. This is a significant disorder that is not getting the finances or economic support that I think it warrants, or the attention that it warrants. And finally, I have there the estimated lost revenue associated with migraine or economic impact, $19.3 billion a year in lost productivity and absenteeism. So this statistic does not include the people that actually go to work with their migraines and aren't doing the job. This is just the people that are missing from work because of a migraine. So now I'm going to start talking about treatment, starting with acute treatment. So when you're getting a migraine, this is something you could take to actually deal with a migraine attack. I have listed up here the triptans, which have been around for a long time. They're FDA approved. Imitrex, Maxalt, Relpax are some of the familiar names that you may know. I have all of the generics listed along with the brand names. And these were revolutionary when they came to the market for migraine sufferers, because prior to this, there was really nothing that was migraine specific out there, maybe some ergotamines that people could take. But these work on the serotonin pathway. They actually stop the migraine attack. The criteria is within 2 hours, but you're allowed to redose 2 hours later if necessary. But they are associated with side effects. One of the most significant is they all cause vasoconstriction, or cause blood vessels to constrict, which we know is part of the migraine process. But because of that, it excluded everyone who had cardiovascular disease. So if you fall into that category, then maybe you've never taken one of these, or you would not be a candidate for one of these therapies. The next one I have up is called a ditant. The medication is called Lesmatadan. It was approved by the FDA in October of 2019. It also works on the serotonin pathway, but it binds to a different receptor on the serotonin pathway, so it does not cause blood vessels to constrict. So it is something that if you have cardiovascular disease, you could safely take. But the exchange for the lack of vasoconstriction is the receptor it binds to. You get a lot of dizziness with it, and kind of cognitive fog or brain fog. So it actually comes with an 8-hour warning that if you take Ravo, you are not allowed to operate heavy machinery or drive for 8 hours. So if you're a patient and this is a medication that is for you, it's not something you can take and stay at work. It's not something you can take really and be anywhere but at home. But there are some people that don't respond to anything else and have to sleep off a migraine. And this is a good option, at least, of having something that's migraine specific that you could take that actually aborts the migraine attack. The next category of medications I'd like to talk about are called the GPANs. And the two that are most familiar are Ubrelvy. You've seen Serena Williams on television advertising that one, and Nurtec, which is being, I think it's Whoopi Goldberg these days. These came to the market in late 2019, early 2020, as far as FDA approval is concerned. They work on the calcitonin gene-related peptide, or CGRP pathway, which is a different pathway than the triptans. And some of the significant differences between this class of medication and the triptans is side effect profile. These are associated with a milder side effect profile of maybe some nausea and some somnolence, some dry mouth. They do not cause active vasoconstriction, so they are actually safe if you have cardiovascular disease. And in the clinical trials for both medications, they included patients that had stable cardiovascular disease. So if they had not had an event in 6 months, they were allowed into the clinical trial, and there were no negative events in those clinical trials. So these medications are also available to you for acute treatment. Rimagepant, or Nurtec, also got a secondary approval for prevention, but I'll talk about that on a later slide earlier this year. The final thing I'll also mention with these is they do not cause medication overuse. Almost every other medication out there that you could take for a migraine, if you take it too frequently, it will give you a rebound headache or a medication overuse headache. So far with the GPANs, there's no evidence of that in the clinical trials, and none in clinical practice at about 1.5 years out of people getting rebound from these. So also a difference. Next, I have listed the ergots, and as I mentioned, they were available prior to the triptans. Cafragot, DHE, or dihydroergotamine, were available in nasal spray formulation, Migranol nasal spray, and injection. And then recently, another DHE product was approved just past week, also via nasal, but delivering it to a different part of the nasal cavity that is in the clinical trials cleaner with fewer side effects, but very effective. DHE works on multiple pathways to abort a migraine attack. It's very effective at stopping migraine and preventing it from coming back. And it's been one of the things that we've used intravenously very effectively over the years, but you can't swallow it. It doesn't work via the GI tract, and it causes pretty significant GI side effects when it's taken intravenously or IM injection. So we're pretty excited about this new formulation of nasal spray that is available as well. I hope you're getting the message that there are a lot of options here for migraine treatment. I can tell you that if I were up here 4 years ago even, and Dr. Young back in the back can vouch for this, we wouldn't be talking about most of this stuff. And that's why I put the FDA approval dates next to the medications, because most of this stuff is rolled out since 2018. So it is a time of positive revolution in the migraine space. So there's also an anti-inflammatory medication, diclofenac powder. The trade name is Cambia, that is available for patients that respond to that type of therapy, or in the past, before the GPANTs, if they were not candidates for the triptans or vasoconstrictive medications, then this would be a good choice as well. And then at the bottom, I actually have devices listed. We call this neuromodulation. There are people like yourselves out there that don't want to take a medication for a migraine attack. They don't want anything in their body. So they would like to do something to treat the migraine without having to take a medication. And there are devices available. There's the Cephaly device, which is a headband that you put on. It's been available since 2014 and is effective for some patients. We also have the GammaCore device, which is a vagus nerve stimulator put on the neck during a migraine attack that will also stop the migraine attack. And then most recently, the Nerivio device, which is an armband that you put on. It stimulates the small pain fibers in your arm for about 45 minutes. And there's evidence that that also works for migraine attacks as well. So medications and devices to treat your migraine attacks. Moving on to prevention. So the criteria for prevention would be if you're having more than 4 migraines in a month or more than 1 per week, that would be a reason to consider prevention with your provider. If you're having maybe fewer attacks than that, but they're really severe, they're lasting several days at a time, you don't have an effective rescue or abortive medication to stop those migraine attacks, that might be a reason for prevention as well. And in the past, if you had certain types of migraine or you had cardiovascular disease and you were not a candidate for the best migraine-specific medications out there for migraine attacks, preventative was the way to go. So you try to stop them from happening in the first place to stay functional. So I have listed up here the 5 medications or 4 medications that were approved by the FDA for migraine prevention prior to 2018. All of them have in common that they were actually designed for something else. And we found in clinical practice they were effective to prevent migraines. So the exchange for that was pretty significant side effects with these preventative medications taken on a daily basis, but they would reduce the number of migraines and the severity of your migraine attacks when they occurred. And so they were available. They're still available if you are not or you are a non-responder to the new agents that are available out there. And there are some patients that are on these medications that prefer them. They've had good control for years. They're not really interested in trying the new therapies that I'm going to talk about next. So they've remained on these medications under good control. In 2010, the FDA approved onabotulinum toxin or Botox injections for migraine prevention with the protocol that came out of a clinical trial. And that has remained one of the most effective preventatives for migraines as far as reducing the number of days with migraine and severity of migraine attacks over time. But those of you out there that are veterans know that not everybody responds to Botox injections. And so while it's been a great tool for us, it's been great to have additional options, which I'm going to get into next, for migraine prevention. So at the top of the slide, I have what we call the MABs. And trade names that you're familiar with are Aimovig, Ajovy, Emgality, and then most recently Vyepti. These are all injectable medications that target the calcitonin gene-related peptide pathway. And basically, the most simple way to think about it is they keep the CGRP molecule and the receptor from coming together. They have long half-lives, so they tend to stay in your system for a long time. So they keep the receptor and the molecule apart for a long time. That results in fewer migraine days in a month. And the side effect profile has been superior to those medications I listed on the previous slide with all the medications that were taken orally for different indications. These have been well tolerated over the last 3 years by the majority of patients and quite effective at reducing migraine days. The Vyepti medication that was approved in February of 2020 is an IV infusion done once every 90 days. So it is different than the other three in that way. And can be a little bit more, I guess, onerous for offices to get authorization and those types of things. And you also need an infusion center. You need access to an infusion center to be able to get the Vyepti infusions. Near the end of the talk, I'm going to talk about the difference between, working with your primary, a neurologist or a headache specialist for your migraines. And this, at this point, would be one that you would, with Vyepti, you're likely working with a headache specialist to get this done, where they have access to an infusion center and a team to get the authorization for this medication. At the bottom, I have 2 oral CGRP medications that are now approved for prevention. One is Remagepant, which is Nurtec, which got approval for abortive therapy back in February of 2020, but in May of this year is now approved for prevention, taken every other day. And then Atogepant was just approved this week. Another CGRP oral medication that we'll be hearing more about in the coming weeks through your providers and through the news. To be taken, also targeting the CGRP pathway to prevent migraine attacks. So when we talk about seeking care for your migraine, first of all, I'll say, and I hope you've gotten the impression from all of the new therapies that have rolled out and the investment that's been put into things that way, but also from the disorder and the description of the disorder, that it is something you really should be under medical care for. This is not a disorder that you want to try to manage at home, taking over-the-counter medications and just trying to get by. And statistically, that is what the majority of people with migraine are doing, unfortunately. It's probably around 50% or 55% of people with migraine will say in surveys that they've never talked to a primary care or provider or medical professional about their migraines. So I would encourage you, if you have family or friends that have this disorder, to encourage them to seek care. So we're gonna talk specifically about that now. So for most people, your primary care doctor is gonna be the first place you're gonna present and talk about that you're having headaches. Hopefully, you're diagnosed with migraine at that point, based on the criteria we talked about. And there are some primary care doctors that will try to treat your migraines or refer you to a neurologist to be seen and evaluated and diagnosed for your headache disorder. Primary care doctors have a lot on their plates. And if you're a person who has complex migraines or frequent migraines, a lot of disability associated with it, I think your threshold should be fairly low for at least asking for a consultation with a neurologist or a headache specialist. I will qualify that by saying that there aren't very many headache specialists available in the United States. I mean, it's something like 650 to 700. So it's not necessarily a visit that you're going to go to the headache specialist and stay with the headache specialist, but a consultation where there's information provided and sent back to the primary care and they partner with the primary care doctor, I think is kind of the wave of the future until we can get more headache specialists trained. But you're going to start with your primary care doctor. There are many neurologists. In fact, most neurologists will see headache. It's like the #1 complaint for neurologists, followed by seizures out there. But as the other neurologists in the audience can attest to, if you're not practicing headache medicine on kind of a regular basis, not that you can't do a great job, taking care of headache patients, but you really have to put in the effort to stay up to date with what's going on. And this is not a knock on anyone. If you ask me questions about multiple sclerosis or Parkinson's disease right now, it would be an embarrassment. I got to be honest with you. I've talked to you about stuff that I learned in residency years ago. It's just very hard if you're not in your subspecialty of neurology to keep up. And so if you have a neurologist that you feel is doing an effective job for you with your headaches and your migraine management, then that's great. But if that's not happening, then that's where you would want that referral to a headache specialist. What kind of sets us apart is that we spend time doing headache pretty much all day long. We stay up to date on the latest and the greatest, so we can bring that to the table for you as a patient. And then there are some patients that have complex and difficult migraines to treat. Those are the patients that I think should be in front of a headache specialist, even though it's a challenge, because we do have access to those latest and greatest therapies, and can be creative if the standard one or two things that we tried do not work. So, you know, those are kind of the criteria. I think if you are having recurrent headaches and you think they are migraine, you need validation of that from a medical professional. If you look at the statistics, the majority of the time you would be right. Again, it's not a disorder that is caused by a brain tumor or something like that, and that headache presents differently. But it's dangerous to assume that's what you have without validation, at least a visit and confirmation of that. So I've got some other things listed up here. If you feel like your diagnosis is not clear, you want to see a headache specialist for clarification of that. And everything else I think I covered on this slide. All right, so in conclusion, migraine is a common disorder. I hope you take that away from this, and that it has a significant impact on people's lives, quality of lives, and economics of the nation, the country, the community. One thing I did not mention is that migraine tends to peak in your 30s, which are typically very productive years in a person's life, either from a family or work perspective. And if you're not there because you're down with a migraine, you're just going to miss out on some things that you just simply cannot get back with time. I hope I also impressed upon you that there are many therapies available, both medication and devices and different things for both acute treatment of migraine and prevention of migraine. So there are a wealth of resources available to you, and that we are here for you, even if you have to wait some time to be seen, to try to provide you with the best care that we possibly can. So with that, I'll conclude, and I'm not sure, Shirley, if you want questions now or later. Okay. All right. Thank you for the opportunity to speak.
Okay, thank you, Dr. Spears, for that great overview. Next, I'll be introducing our next guest speaker, Dr. White. Dr. White is a neurologist and current headache medicine fellow at the Jefferson Headache Center in Philadelphia. She graduated from the George Washington University School of Medicine in Washington, D.C. in 2016 and completed her neurology residency at Thomas Jefferson University in Philadelphia in 2020. She plans to be a general neurologist with specific interest in treating patients with headache. As a person with migraine herself, she understands the challenges in the journey to diagnosis and treatment of headache disorders and the need to increase awareness and advocacy for others with these conditions. Dr. White is passionate about diversity, equity, and inclusion for underrepresented minority populations, specifically Black, Latinx, LGBTQ+ communities. As a Black woman and a member of the LGBTQ+ community, she is no stranger to intersectionality and diversity. She has also spent time living in Guatemala, Spain, and Colombia to improve her Spanish proficiency and to learn how to provide culturally competent care to the Latinx community. At the Jefferson Headache Center, she is creating a program that allows underserved patients to have access to affordable, high-quality care for their headache disorders. For her, advocacy is about education. Dr. White loves teaching medical students, her patients, and the community in general. She believes education is the key to equality and advancement. Dr. White's hobbies include writing, reading, playing board games, and trying new kinds of tea. Her favorite tea is Earl Grey, but she says she is always up to new recommendations. So please put your hands together for a warm welcome for Dr. Courtney White.
I just want to make a clarification and apology. Dr. White is no longer a fellow. She is now an official attending doctor at Jefferson.
Yeah, I've been in attending for 3 months now, so it's still pretty fresh. All right. So, thank you for the introduction. So, just like it was said before, I am a neurologist and a headache specialist, but I'm also a person who lives with migraine disease. I had my first migraine attack when I was 23 years old. And I still remember that day. I was sitting on a train and, the pain just hit, the sensitivity to light and sound, and I knew exactly what it was. And that was because at the time I was a medical student, so I had learned a little bit about migraine. There was a lot of folks in my family who also have migraine. I remember when I was younger, my mother, she would have her migraine attacks and she'd be driving and then pull over and feel very sick. So I knew what was going on. But even at that time, when I went to go see a doctor about this, because I knew I needed treatment, I realized looking back on it that I actually didn't know a lot about migraine like I thought I did. I thought about through my journey where my diagnosis was not actually correct by some of the medical professionals. My management was not up to the standards at the time. I actually went through 3 different providers before I found one who could put me on a treatment that was appropriate for me, for my quality of life, my needs. Other providers kind of gave me the outdated treatments. I brought information because again, being a student, I was learning a lot. And even kind of thinking back, I had quickly developed from episodic migraine to chronic migraine, which means that I was having headaches and migraine symptoms more days than not. And that could have been prevented had I gotten the correct treatment sooner. And this is the story of someone who was in the medical profession, who had an interest in becoming a headache specialist, who had access to all this information. And yet still, it took 4 years before I could get on a regimen that worked for me to control my migraine disease. Now imagine if I was someone who didn't have family members with migraine, if I didn't have that access to the knowledge, if we didn't have the internet available, we didn't have events like these where we can talk about this. Y'all don't have to imagine it. We've all lived it. Now, let's take a step further. Imagine on top of all of this, when you do reach out for help, you're dismissed, told your pain can't be that bad, labeled a drug seeker. You're told it's stress related, just don't stress so much. So you look online and you start seeing pictures and images of other people who have migraine, but none of them look like you. You go to providers saying, I think I have migraine, I need help. And those providers say, can't be migraine. People who look like you don't have migraine. Those providers are taught, truly, that someone with migraine has a very specific personality, image, lifestyle. This is the experience of people of color who have migraine. So take all the stigma, all the lack of access, all the lack of information, misinformation, all the stigma, add on another form of stigma and healthcare discrimination. Black people are even less likely to be diagnosed with migraine and managed appropriately. We also have to take into consideration the history of medicine with the Black community. There are still providers to this day that believe Black people do not feel pain the same way that white people do. There's this thought of thick skin that's dated back to even times of slavery. they are even more often considered pain seekers, and that there's something that they have done to cause their disease. Migraine doesn't discriminate by race, but it's always been marketed as a white middle-aged woman disease, and that's what I was taught. And this kind of branding prevents even more people from getting appropriately diagnosed. Half of medical students still believe today that Black people don't experience pain the same way white people do. There's even a nursing textbook that was published in 2017, and this section has since been removed, but there's an actual section written in there that says that Black people don't experience pain the same way. So you all know, finding somebody who can diagnose and treat your migraine disease appropriately, it's already hard to find somebody, someone who believes you, who understands you, who will work with you. But finding someone who understands the other cultural and social barriers that are specific to Black people is even harder. So there was a survey that was done, the AMPP, and they basically would talk to people, ask them about, their symptoms, and they asked, were you diagnosed with migraine? And they found that more Black people who were surveyed had the symptoms of migraine, but were not diagnosed compared to their white counterparts. And without that diagnosis, how do you get the treatment? How do you get the accommodations? How do you get that support? I love to teach. My form of advocacy is education, both within my patients, within the community. As some of you know, I'm very involved in social media as well. Trying to get that information out there, because we don't have time with our doctors, to be able to really go through all these nuances. And it's amazing the feedback I've gotten from people. I think about my experiences of people with migraine, particularly those who don't fit that stereotypical look. I had a patient once said to me, well, I've had headaches since middle school. I thought all women just went through that. When I diagnosed her with chronic intractable migraine that she had had for years, completely untreated. I had a medical student recently, as I was teaching him, he said, oh my goodness, I think I have migraine too. I need to see my doctor about this. He had no idea that someone like him could have migraine. Even just I went to a grocery store. I was visiting family, went to a grocery store. I'm talking with my mother. Another woman comes up and she says, excuse me, you're talking about migraine. And I said, yeah, I'm a headache doctor. I do. And she said, and we just started talking. And I said, yeah, there's a lot of great treatments out there that are pretty new. And she was like, oh, I thought it was just something you have to suffer through. And she said, and so she was very grateful. So just those little things day to day can really make a difference. And that, my friends, is advocacy. Advocacy can be something as little as just the conversations you have with people day to day. It could also be something as, extensive as a race like this, or going to Headache on the Hill and talking with Congress folk to change legislation, get more money for research. But it could also make a difference in the day-to-day life of someone who didn't know they could have migraine. And it's especially important, especially now, that all of us here are advocates, but we also include Black voices, because their experiences of migraine may not be quite the same. When you add on the history of racism in this country and the healthcare system, we need to know about these things, because these are also barriers to appropriate treatment. Commonly, people will say, and I'm sure you've heard this one before, your migraine will get better if you just don't stress so much. Yes, stress can affect your disease. But let me tell you this, no amount of mindfulness meditation and relaxation techniques will cause me to not panic as I'm driving by and I see a police car parked on the side of the road, because I'm afraid they're going to pull me over and I'll end up on the news as another name, another hashtag. No restructuring of my schedule will remove the burden of microaggressions living in a world where my worth is seen seems to be less as a Black woman. No Relaxation has the time, resources, and support to make sure that migraine research includes people of all different backgrounds. And unless we start seeing ourselves as the face of this disease that does not discriminate, we're not going to change things. We need people of different experiences because migraine is just as diverse as all of us. And we need to be open to discuss the unique challenges that every individual has. So I know there's a lot of white people in the audience today, and often I get asked, what can I do? And my advice to you is first to listen. Listen to others in the Black community when they talk about their experiences. And I know your first instinct is, well, I have that too. I experience stigma too. You do. This is not to say that your experience is any less, but always remember that your experiences dealing with the healthcare system, dealing with getting diagnosis, dealing with even knowing about your disease are not due to the color of your skin. And that there is something a little bit more that can be creating another barrier. What you do not experience is the additional stigma, shame, lack of access, and negative personality traits that are attributed to you solely for the color of your skin. So just listen. Give us all a space to talk. We can all talk about this, but be sure to listen. The migraine advocacy world needs a population that reflects the diversity of the population that's affected by migraine and other headache disorders. And we all need a seat at the table so that our voices can be heard and changes can be made to improve everybody's lives. We're not a single monolithic group. We are not the migraineur. That's not us. So let's talk about it. Let's tell others about it. Tell about your experiences. Listen to other people's experiences. And have the strength to say, I have migraine. This is a neurologic disease. It's different with every person. What may work for you may not work for me. Your experience may be different from mine, and that's okay. We all need to work together to make sure that we're not just going to deal with it, that we're not just going to stress less, or we're not just going to take people who are saying, oh, well, you're a drug seeker. No. We are not going to stand for that anymore. None of us are. Thank you. Much appreciated.
Thank you, Dr. White, that was very powerful. And I also want to add that something else you can do is you can join our Advocacy Connection team, which is a training program that we do. And when you complete the training, you can actually do a project if you so desire. And we really need more projects that will encompass bringing in people of color into our community and getting people diagnosed. So with that, I'm going to stop and I'm going to ask you if you have any questions now. I'm going to come around with a microphone and I'm going to hold the microphone in my hand because of COVID protocol. I'm just going to put it in front of you. These two amazing doctors can probably answer any question you have as long as it is not a specific medical question, which I'm sure they will let you know if it is. And you can raise your hand and we'll take turns and I will come around with my microphone. Hopefully it doesn't make a lot of noise.
We have a lot. Thank you guys, both doctors, for that presentation. I always learn more, and that's what's always good about this, about talking about it. But how do you convince people who have been shunned, disbelieved, pushed aside, dismissed, misdiagnosed. How do you convince them now to come on into the tent? We're here to help you.
That is something that I've definitely found a challenge. I've had a lot, especially young Black men who have, throughout their life, in a lot of them do have chronic intractable migraine that, if it had been diagnosed earlier, it may not have progressed. And it definitely interests me when I say, okay, this is what you have. There are treatments available. And they said, no, I don't want this. And part of it is just understanding the history that goes in the healthcare system, that, especially a lot of people of color were either given medications without their consent. There were a lot of clinical trials where they were not given consent. They were given treatments that are subpar. And so here I am, a whole new face, giving them a whole new diagnosis, a whole new treatment option, and they don't want it. And I'm surprised because as someone who also has migraine, I'm like, why don't you want to get this disease under control? Don't you want to go into remission? But it's really understanding that this is where they're coming from. This is their experience with the healthcare system. So I think the biggest thing for me to help convince them is, again, like I said, listening to them, listening to their concerns, and letting them make the decisions as I provide the information. And sometimes it does take multiple visits, multiple times, talking about things, giving them information. I think that's been the most helpful in getting people to finally kind of move over. Definitely sometimes you just can't do it on the first try, but really understanding why there may be some hesitancy, especially things like the new medications. We're all excited about them, but imagine someone who is saying, well, why are you experimenting on me? So I think, again, letting other people talk their experience, let people have their experience, give them the information, and just keep the conversation going.
That's a real challenge. I think appealing to the impact on a person's life and how it could actually be better, but sometimes it's people don't actually believe you until they get better. So they have to get them to the office visit in the first place is a real challenge. One of the things I have found in research is representation does make a difference. So especially for Black men, if it's a Black male provider, that makes a huge difference for Black men in the United States. So if there were more Black neurologists, Black male neurologists, or headache specialists, that would make a difference.
I wonder, how much do you feel poverty plays into the lack of folks getting treatment? I know over the years I've spent thousands and thousands of dollars on treatment, and if you don't have a lot of money, you may be very well discouraged to go and get treatment at all. And so how are we handling that population of folks?
Well, you're right. From the perspective that a lot of these new therapies, there are programs for commercial insurance to decrease costs for the new therapies, and that's not available through government programs. So sometimes it is a waiting game, unfortunately, to get access to those new therapies. But those older therapies that I mentioned are available, and some of them are not very expensive. And this is, unfortunately, for better or worse, a step-by-step process where you start with what's available to you. And then as time progresses, the newer therapies become more affordable. But, it's something to look at in our healthcare system in general. Why is it that, people that are not as economically advantaged don't have access to these therapies? There are programs available, but you have to be pretty poor to qualify for some of these programs where they'll just give you the medication for free or very low. But that's where we sit today. So.
Yeah, and I could talk for hours about how our healthcare system does not benefit people who cannot afford it, but that's a topic for another day. Some things that also are to take in mind is that medication is very important and it's necessary to treat this disease. But let's also look at other non-medication options that may be more affordable to add on to some of these, older regimens as well. And especially doing things, providing other techniques like mindfulness techniques, which have been helpful in decreasing disability from the disease. Having that information, having that support to be able to kind of make a more comprehensive care can sometimes be a way that we can get around it as we're trying to get access to some of these newer treatments. And there are people out there. So one of the things when I was a fellow was developing a program where people were able to get access to high level headache care when they normally would not be able to afford it. And it's still a process. You still have to see a general neurologist first. You have to be seen by a resident who is a physician in training, and it's still a long pathway before you can get there. But it's, and it really is a Band-Aid on a bigger systemic issue. But I think, a combination of working with what we've got and advocating for better coverage and better support for people who cannot afford it. Because having migraine is very expensive.
Hello, thank you both for taking time out on your Saturday to inform us today. Um, One of my son's providers, he was concussed at 12, and so his migraines, I think migraines began there. He's 19 now, and he has headaches all day, every day. And because they present in different areas of the head, cluster versus tension, I'm not really sure that migraine was provided as a diagnosis. Is there a difference between migraine and cluster headaches, or does cluster fall under the migraine umbrella?
No, there's a difference. Both headaches are on one side of the head, but how long the headache lasts is different. Cluster is a short disorder, 15 minutes to 3 hours. It can occur multiple times a day. Migraine, 4 to 72 hours. The cluster patient is agitated during the attack and wants to move or pace the floor. The migrainer does not. Movement makes the headache worse, so they typically don't want to move. And so there are some differences in diagnostic criteria that a medical provider should be able to know or look up.
Good morning. So this is not I wouldn't consider this a specific medical question, but it's more, I'm asking a question about your experience of if you've seen a case similar to this. But say you have a child that experienced a mild traumatic brain injury around, say, age 8 or 9, and it was never diagnosed. Just thought that the child hit their head. They didn't have any bleeding or any, they just fell asleep for a while later on that night. And then, as far as you know, as a parent, everything is fine. Now, years later, the child is 18 and tells you, that they're having basically what would be cluster, and they've been having this sharp pain every now and then, once a month for many years. Um, Now, so say now you recognize that this child may have experienced a mild traumatic brain injury as a child. So research shows that the brain can possibly heal, with time. So what my question is, um, have you, in your experience, ever seen so where someone was experiencing these migraines, but as they're because as a child, if this person it wasn't taken into account for it, so they were just in school, they were still doing everything, they were experiencing these issues but no one knew what was going on. So now once those things are uh known, and you start making, and this person their brain starts to get a chance to heal, have you ever seen cases to where the brain has healed and then the migraines have gone into remission?
So I have seen cases where people have had trauma as a child, but typically if it's a significant brain injury, they'll have other symptoms at the time. It's hard to go to school. There's dizziness, headaches, impaired concentration, things like that over time. So it's kind of unusual to have a brain injury and then kind of be symptom free until you're 17 or 18 years old. and then start to develop headaches. As far as making a connection between the two, um, a migraine is a disorder that will start in your teens to early 20s. And so, you know, in cases like that, I do what I do with all my patients. I take a headache history and kind of go where it leads. And so if it turns out that it's a diagnosis of migraine or cluster headache, I'll ask about traumatic injury or brain injury in the past. But I usually just go kind of where the history leads based on diagnosis.
Hello, people of color. I have a free relative who have severe headaches. I don't think they were ever diagnosed because they never said they had migraines. But their PCP would say, you have high blood pressure. I hear this all the time. High blood pressure and migraine. What do you think?
That is very, very common. So you can have both. And is it that your blood pressure happens to be high when you're having attacks because you're not feeling well? We know now that for a lot of people, it's more genetic. It's less of a vascular or blood vessel disease as what was thought before. And a lot of people, yeah, you could treat the blood pressure, but if those headaches don't go away, you got to treat it as something separate. So I think it's important that both are addressed. No matter what the cause is, you're having symptoms that are bothersome to you and they're affecting your life. So they still need to be treated regardless. And I think it comes down to that kind of like that blaming system that, oh, well, if you just fix your blood pressure, you'll be fine. Not everybody is. Yes, some people do get headaches with high blood pressure. You treat the high blood pressure, those headaches go away. So it doesn't, to me, I find it doesn't matter what the cause is. Let's treat it and get you feeling better, whatever way it needs to be. And I think that comes down to that a lot of doctors, again, most medical students only get 4 hours of training on how to treat headache disorders. So they already come with probably less knowledge than a lot of us here have. So being able to say like, okay, sure, fix my blood pressure, but I'm still having a headache. So let's talk about that because it's not just the blood pressure.
Yeah, I would say that's the key. Is it, hey, this is a blood pressure headache, and then, okay, so you treat the blood pressure, then what happens to the headache? Does it get better? Or if it persists, do you persevere as a provider and try to help that patient get better? And that's the challenge for the patient sometimes, because you have to advocate for yourself or have someone in your family advocate for you to say, hey, this isn't, I'm not as well as I should be. Can you help me, or can you send me to someone who can?
Hi, my question is, I'm an African American and I've been having migraines for many, many years. But I've been attending the Jefferson Headache Center for many years before they were at Jefferson. I was attending in Germantown Hospital, and I've been getting the treatment for many years. I've had different types of insurances. I've had jobs, whereas I had insurance, and then it was times where I didn't have that type of insurance. So they were at the Germantown Hospital. I was there, and then when they moved over to Jefferson, then I was there. So I've had the center. So my question is to just actually tell people that they're African Americans, that I'd recommend everybody to go to Jefferson. If they have a headache, if you have a headache, go to, migraines. Jefferson is the place to go. And I tell everybody, my family members and everyone, to go to Jefferson if you have treatment. It was a while years ago to get in there. You had to be seen and you have to wait. It was a waiting list. But after that, I've been going there for years,
And you're happy there. Okay, well, and Dr. Spears, I bet you his patients are happy. So,
Thanks,
hold
Shirley.
on. All right, another question here.
My question is about funding. So where is the bulk of the funding coming? The reason why I'm asking is I'm a grant management specialist at the National Institute of Mental Health. And so I see a lot of funding that we give out. Has anyone that you know reached out to the National Institute of Health to look for federal funding to assist with that?
I'll do that because Miles for Migraine is always looking for grant funding.
Well, we have 27 ICs. As most of you are familiar with Dr. Fauci, he's at the National Institute of Allergies and Infectious Diseases. I am his colleague. I'm at another IC. And we do have small business grants that we give to businesses that are connected to institutions for federally funding at all 27 of our ICs. So I didn't know where funding was coming from. And I know with this being new, even though it's not new, as far as knowledge is concerned, has anybody ever considered the National Institute of Health?
You know, I just before you answer, I want to add on something to that. I think what is also disparate in our community is the lack of awareness of mental health and migraine and other headache disorders. And so I wonder also in populations of color in the BIPOC community, how that is an added burden and what can we do? I don't expect you guys to have the answer to this, but if you want to comment, go ahead.
Yeah, mental health in definitely in the Black community also has a lot of stigma associated with it, and that's a whole separate, thing that probably we wouldn't be able to talk about too much here. It's a whole can of worms, but yeah, just being able to have the fundings for these communities as well, and the advocacy and the education is going to be important as well.
So Headache on the Hill was mentioned earlier, and and Bill, you may be about to talk about this. One of the things is the mismatch between NIH funding for migraine research compared to the number of migraine sufferers that are in the United States. It's, and this is something that we've been as a society, a headache society, advocating for a long time with the NIH through Headache on the Hill. So I don't know if Bill wanted to comment more on that because he's really involved.
Yeah, I'm the past president of the Alliance for Headache Disorders Advocacy and Headache on the Hill. And we've been going to Congress, and almost every year our ask has been to get Congress to put pressure on NIH to fund more research to help people with migraine and cluster headache and other headache disorders. And while there's been a little bit of a creep up over the years, it's been really disappointing. And I'll be honest, I know where you work and I respect the NIH, and it's been amazing for health in general, but it has not been amazing for the headache community. We get funded at about 30 million a year. If you look at the actual impact of migraine disease, it should be around 240 million. So we are getting, whatever that is, an eighth of what we ought to be getting, a tenth, or something like that. And if you have any thoughts like how to knock some heads, just as an example, the headache community looked to turn some of the dollars allocated for the opioid crisis to do research in pain. And the idea was that if you learn how to treat pain better, you'll create less of an opioid problem in the future because you're successfully dealing with pain without using opioids. And so far, none of that money. It's like we scored $200 million a year for the NIH and zero has gone to migraine, So I'm sorry to, unload my guts on you, but but any help you can give, please go to NINDS, tell Yeah.
It's 27 institutes and centers. They're specific
Right. Well, some of our asks are to NIH in general, and then some are to NINDS. We're usually directed to NINDS, but there is a lot of overlap, and we want to learn. You know, we're a small group. We need, if you want to help us, if you're allowed to, you're probably not because you're employed by the U.S. government. But if you could, we would love any advice that you can give us. Please, we got to do this better.
Okay, we're going to take 2 more questions because we're just about out of time. Coming over to you. You didn't, let me ask, he's going to ask first. Okay.
In my more ignorant days, it was difficult for me to connect migraine as a disease like other diseases. But I've heard multiple times you talk about remission. What does that remission look like for migraine sufferers?
It's different for different people. For some people, it means, that they have low symptom days, more days than not. Some people, it's no symptom days. It really comes down to your quality of life and being able to have a control over your disease, that when you do have flare-ups, when you have migraine attacks, you can treat them and you can keep going. As of right now, we do not have a cure for migraine. So this is something, even if someone is episodic and has a migraine attack a couple times a year, it's still a disease that affects them every day. And you can, and people will say things like, oh, well, I'm not going to go out and party tonight or, stay up late because it might trigger a migraine. That is still affecting your day-to-day life. And even if you're not having a migraine attack at that time. So remission is really the idea of having whatever you personally consider as control of your disease to the point that you're living the life that you want to live and be able to do the things you want to do, whether it be with more no symptom days, more low symptom days, low pain days, less exacerbations. When they do get bad, you're able to treat them. That's kind of where we go on, what that kind of means.
Okay, we'll take 2 more questions and that'll be it. Okay, go ahead.
I just had a question about Dr. Spear's steps to treatment. You mentioned that you start at the primary, then you go to your regular neurologist, and then you get with a headache specialist and stay in front of that specialist when you don't have treatment that's working, and you stay with the headache specialist till you get on a plan that's working for you to bring your headache levels down or your headaches to go away completely. Is that correct?
In an ideal world, in the majority of cases, once migraine patients with a headache specialist, they often want to stay with the headache specialist because of the optimal control. So for my patients like that, I'll see them once a year to keep them active. But they want to maintain the connection to a headache specialist because if things change or go poorly, they want that connection because of the path to get there in the first place.
Yeah, I have some patients. I think of some particular patients who with cluster headache where you can go for years without symptoms and then you get hit pretty hard. To have a doctor who understands what that is, as opposed to someone who might be a little less experienced, to be able to call up and say, hey, I'm back in cycle. And the same thing with migraine. You could be under control for years and years, and then something happens and you kind of get a little bit out of control. To have someone who'd be like, all right, let's go right now, and not have to go through the whole process again. So that's one of the benefits of having a headache specialist. But again, there aren't enough of us, so it's you have to go through this pathway to get to the specialist. So there's things that are being done, in terms of educating more general providers, general neurologists, primary care doctors. In particular, there are some headache certification programs, but that's also why it's important on us as the patients, as advocates, to be able to spread this information. I've had a lot of patients who, some of the information that I have given them through social media, they'll bring it to their doctors. They'll bring the studies to their doctors. And sometimes that can make a difference as well. I couldn't hear that.
Doctors open to that.
Some are.
Hi, oh, sorry. Yeah. Do you have any experience with people presenting headaches in their later years, in their mid 50s and on? Because that's what was my case. And, there was no specific trigger at all, other than perhaps some more generalized anxiety. But beyond that, there was no specific trigger. And then also, I've been trying some of the injectables, and do you have experience with them working for a period of time and then not working? So it's sort of a two-part question.
Yeah. So, we always talk about how migraine kind of affects you during your, you know, teens, 20s, 30s. And again, that's probably the more common, but it's not for everybody. And I definitely do see people even in their 70s, 80s developing, migraine as well. And that makes treatment tough because studies and clinical trials tend to fit a very specific population. So there definitely needs to be more research in these other populations that don't kind of fit the typical one. So that's kind of the first question. It happens. It's not, it's not unheard of. It's just, again, more common in this age, but again, not unheard of. And I do see it, quite a fair bit. And then, I guess Dr. Spears talk about, more you might have had a little more experience than me with some of these injectables because.
Oh yeah, sure. So yeah, I agree. I definitely see patients over age 50 with new onset headaches. My approach is a little bit different, I guess, in those patients from the perspective that my threshold to rule out a secondary cause is higher. But once we've done that and the diagnosis is migraine, we just get started and move forward from there. And yes, I've had patients on the injectables that responded for a while, and then we needed to change to a different one. And then that didn't work for a while, and we had to change to a different one. So yes, there are definitely people out there with challenging migraines. It's kind of a moving target.
Okay, well, we've had a very fulfilling morning. I think we really got a lot done here. I know you probably still have more questions, but I'm going to recommend if you are interested in looking for a provider in the Philadelphia area, we do have three um, uh, medical systems here. We've got Penn, Jefferson, and Mainline Health have headache specialists. If you want more information on where to find a doctor that treats migraine and headache, you can go to the Miles for Migraine website and go to the part that says migraine, and there you will see a link to actually other websites that harbor all this information about where to find a specialist. With that, I would just want to say the only way we're going to get more research is if you keep advocating and donating. If you want to donate to Miles for Migraine today, we would really love it. You can do that on our website as well. And I hope that you will consider coming to more of our events. They are also on our website and in our newsletter. And thank you to our sponsors. And please get one of those water bottles so that young lady doesn't have to leave with all of those. And also, please stop by these tables on your way out because they have valuable information about treatment. Thank you all for being here.